Did everyone complete their TRATs there? Okay. Okay, let me close this other extraneous window and let's just go right into this. Now, you should see a PowerPoint screen that just says TBL 3 rats. Someone give me a thumbs up. Okay, good. So let me put on my laser pointer and we shall progress. And my my mic is okay. Seems okay. Okay, good. So question number one was kind of bizarre. Probably not something that's going to happen to you when you're sitting in your office or clinic. But it does test multiple questions about your knowledge about iodine, because you need to understand iodine to understand how thyroxine is made. And so let's see. Okay, I'm just kind of highlighting the buzzwords that you've probably figured out already. Let me just go through this quickly because I want to spend more time on the other questions. So A says, we don't care about iodine supplements because there's so much thyroglobulin in your thyroid, it should last for years. And I think tucked away in one of the slides, it said you have enough thyroglobulin and thyroxine to last a few months. So just kind of keep that in the back of your mind, that you do have a fairly large reserve of thyroxine in your thyroid gland, but it's not forever. A few months is probably all you can go for. Actually, I was kind of curious because you probably have heard the story about, sailors, especially in the British Navy, that were at sea for months and months, that they would often develop scurvy, which was due to vitamin C deficiency because they had such a poor diet. And I kind of wondered, do British sailors during that time, did they get, hypothyroid from lack of iodine? And their answer is no, as far as I can tell. And I think one part of the answer is you have a large iodine reserve or thyroxine reserve within your thyroid gland. And second, anything that comes from the sea, I'm sure they ate some fish that they caught, is full of iodine. So that's just a factoid. You have some thyroxine that lasts you, but not for years. Second, astronauts need to take supplements of 100 to 150 milligrams a day to ensure health. And the main thing is the amount here, milligrams. You need about 50 milligrams per year. So if these astronauts are really taking this amount, they're getting way too much iodine. So just remember, the amount of iodine you need per day is in like picograms, is a small amount. And then finally, D has to do with the question of using potassium iodide pills and radiation exposure. And this is something I just mentioned real briefly in the pre-read. And for people that are into surviving the next nuclear holocaust, one of the things they like to keep in their survival kits is sodium iodine pills. And if you go on the internet, you can find people that will sell you little packets of iodine pills. And I think you might have heard, when certain nuclear reactors explode, they release radioactive iodine. And I believe in Chernobyl and Fukushima, you might have heard that they're passing out these iodine pills to everyone to take. And so the reason for that is when a nuclear bomb goes off or a nuclear reactor explodes, it releases huge amounts of radioactive material, including radioactive iodine. If you're anywhere near that area and you eat, breathe, or drink any of this stuff, your thyroid's going to pick it up. If it concentrates in your thyroid, you are at increased risk of developing malignancy in your thyroid. So that's what the concern is. And the idea is if you take a large dose of iodine, you saturate your thyroid and you won't absorb this radioactive stuff floating around. So that's why people use that. So the question is, why don't you want to do this with astronauts? And my explanation would be, yeah, there's lots of radiation in space, but it's not radioactive iodine. Now, one can argue that, the astronauts do have iodine in their thyroids and they are getting exposed to radiation. Maybe they're getting radioactive iodine in situ within the thyroid. Yeah, well, that I don't know, but taking iodine as a supplement isn't going to change that fact. So now I did check the NASA website, and there is all this discussion about astronauts on a long voyage, let's say to Mars, and all the radiation that they're going to get to. And someone did mention, maybe we need to give astronauts going to Mars, iodine tablets to prevent radiation sickness. But it was only mentioned once. And there's a lot more discussion about methylgreen and some other things to prevent radiation sickness. But I think that statement about astronauts take potassium iodide was probably incorrect, because it's only mentioned once in the whole series of articles. So that was mainly to test your basic knowledge about iodine. So the answer is C, and I think everyone did well on that. Okay, question 2. Let me start the process of calling on teams here. Let's start with team 13. I like that number 13. Can someone from team 13 tell me what they think about A? What do they think about the possible answer A from team 13?
So we thought that it's correct that it's on the cell membrane of the thyrocyte, but we thought that A was talking about the wrong side of the thyrocyte.
Okay, and let me just kind of pick your brain. Okay, what is touching the apical side of the thyrocyte?
The colloid.
Colloid, yeah, very good, excellent. I like that. Okay, because the sodium iodine supporter is bringing iodine into the cell, so it's coming from outside, and the blood vessels are actually on the basal side, B. And because we know the sodium iodine supporter is bringing iodine into the cell, pretty much we know it's got to be on the cell membrane. So these other answers are probably wrong. Okay, thank you. And this was the image that's in the pre-read, and it's pointing out the NIS, the sodium iodine supporter. Okay, it's on here. Now this diagram is a little confusing because it's flipped around from how we usually show it, because this is the basal side up here, because here's the blood vessel, and the colloid is on this side, the apical side. And just to add one more factoid, there's another sort of transport system called penderin, and they take iodine within the cytoplasm and they push it into the colloid. Okay, but this, you have to look carefully at the diagram to see where the colloid is, and that gives you your bearings. So this is what I prefer to show people. So we're all systematic. We have our up and down, so to speak. This is how we usually show it, the basal side down here. It kind of makes sense, basal side, basement, bottom, and the colloids up here. But this particular diagram is flipped around. So, like all things in life, you need to get your bearings. Colloids up here, colloids down there. I think this diagram is really great because it summarizes absolutely everything. I think I used this in the ILS session. And I have a different image, I think within the TBL itself, but it covers the same points. I would encourage you to study these diagrams that summarize absolutely everything, because you need to know what's going on and where it's happening in the cell. So the location. Okay, so the answer is B, on the cell membrane on the basal side. 3, okay. Blah, 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 new test. We give someone radioactive iodine. We do a scan. The question is, what part of the body is concentrating iodine? And so let me pick a different group here. Let's go to the other side. Let's try group 4. Group 4.
That's so funny. So we debated over this for a while.
Yeah. So what questions what answers were you debating about?
So we had all remembered in the reading that the salivary glands absorb some iodine,
Mm-hmm.
and it can be absorbed through the stomach.
Mm-hmm.
My thing was that it says a few days later. And so if you're looking at the radiated iodine, I was thinking it would all be concentrated in the thyroid. You still might see it in salivary glands, but I didn't like stomach still. So I was choosing B, and the rest of the group did D, and it ended up being D was right. But I didn't understand why it would still be in the stomach.
Okay. Well,
So
the reason, well, the quick answer would be these glands concentrate iodine, but they don't synthesize thyroxine. And so they collect it, but they don't get rid of it. And so if they pick it up, it'll stay there as long as there's some dietary source of iodine. So it keeps everything in balance. Now, if someone were to suddenly have every piece of iodine removed from their diet, it's possible these sources of iodine would be somehow transported out of these tissue organs into the circulatory system. But pretty much in most human beings, once iodine gets into the salivary gland, stomach, I believe choroid plexus was the other item, they'll stay there. And so, but I like your reasoning. You're thinking about this. So, I give you a thumbs up for that. And let me just spend a few minutes here on, you may say, well, am I just memorizing factoids for no good reason? Well, there's actually a reason why I want to include this. And I apologize, this is second year material, but I think you guys need to be exposed to this, and that helps you to understand why we're throwing all this seemingly random information at you. Okay, so here's the image from the pre-read that kind of helps explain. This was to talk about how iodine gets into the body. You eat it, it goes to your stomach. From the stomach, it goes to the intestines, it's picked up, goes to circulation, goes to thyroid. If the woman's lactating, it goes to the milk, blah, blah, blah. Okay, so it goes around and around. But as you pointed out in the pre-read, it says, other tissues absorb iodine, salivary glands, stomach, choroid plexus, and lactating breast. Okay, so how do we use that factoid? And it has to do with what we call nuclear medicine. They have a way of scanning the body. And if you give a patient a low dose of radioactive iodine, and then you come back later and you put a scanner on the patient, usually the patient has to literally just lie still on top of the scanner, and it looks for a radiation signal, and then it forms this image. And this is a really old image, and you're saying, what the H am I looking at here? Well, there's actually a head up here. This is the neck. And you can kind of see maybe an arm is here, and then the abdomen and gut, and then something here. So I put this other image here just to kind of give you a reference. I tried to make it roughly the same size. So this is somewhere in the neck, and this is somewhere over here, probably, under the spleen or next to the spleen. And this is over here, the bladder. So this highlights what a nuclear medicine scan looking for iodine would show. It would show the salivary glands pop up because salivary glands like to suck up iodine. This one shows iodine concentrated in the thyroid, and actually this thyroid is enlarged. This patient is having the scan because they're actually hyperthyroid. So this is sort of like, this makes sense. But there's also the stomach is lighting up. And again, this stomach is kind of J-shaped. And if you remember way back yonder when we were talking about imaging the GI tract, depending on your body habitus, then people tend to have stomachs that kind of dip down like that. And then finally, iodine does go to your kidney, but the kidney doesn't hold it. It excretes it in the urine. So, after several days, you're still going to have a little bit of iodine there. So with your knowledge about where iodine goes in the body, you can help understand why it's highlighting here. And with your knowledge of thyroid metabolism now, you understand, hey, maybe this shouldn't look like that. Now, the other thing I just want to point out is, I wasn't sure how to look this up. That's kind of interesting thing about teaching is you say a lot of things, but you want to make sure you're saying it correctly. Actually, the iodine isotope is I-131, And they get, like I said, they give a very low dose for this type of study. And this is a very old scan, so it's really kind of sketchy looking. I mean, it looks real fuzzy. They have better machines now. They give a much more refined image. And they also have a way of combining this with an MRI scan. So it looks even better yet. But this is the basic principle. But anyhow, I went back and looked at I-131, and I was surprised. That is the radioactive compound that is released by nuclear reactor explosions and nuclear bombs. So, you know, that's a bad thing to have. But the trick is it's a very small amount. And apparently we don't think it causes cancer. But then again, I guess if you get, 50 of these nuclear scans, then you're putting the patient at risk for developing thyroid cancer. So let me show one more image like this. Now, this is the history is a patient has a prior thyroidectomy, and they found the patient had thyroid cancer. So that's a good thing. You probably want to get rid of the thyroid that's got cancer. Now the patient says, I got left shoulder pain. And so they give the patient a very small amount of I-131, and maybe the same day or next day they do a whole body scan. Look at this here. So let me pick on someone here. Okay, I want someone to play nuclear medicine scientist here. Let's say group 7, lucky group number 7. Can someone from group 7 look at this nuclear scan and tell me what in the heck they think is going on here?
Sorry, I'm trying to look at it and think.
Okay, so let me kind of guide you through this. So the first thing is, we know the thyroid picks up iodine like crazy, right? Do you see the thyroid here?
No, it seems like it's concentrated in the left shoulder.
Right. Now, why don't we see a thyroid here?
Oh, because of the thyroidectomy. Sorry.
That's right. It's gone. Okay, and what do you think this blob is here? What's under the left diaphragm?
Is that stomach? Oh,
Stomach.
sorry.
Yeah, there you go. See, maybe this is your calling. Maybe you need to go into nuclear medicine. You can make sense out of these fuzzy images. Okay. Now, the person says he's got pain in the left shoulder. Whoa, what is this? What do you think this means?
Is there potentially like a nodule there or something that would be?
Yeah, what kind of nodule would pick up iodine like that? Why don't you share the fun? Pick on someone else in your group. Just call them out. Don't be afraid. Just call. Okay, let me fix one.
Yeah, Mika can go.
Okay. Or let's see. Maybe Brianna. Is Brianna there? Brianna, you're in group 7, right?
Yeah,
Or
I'm here.
Okay, she's there. Hey, you can't hide from me right now. So something likes to pick up iodine here in left shoulder. What do you think that could be?
I'm not 100% sure, but based on the IRAT, since we did say salivary glands can absorb iodine, would that potentially affect like why in the shoulder region?
Would you expect to find a salivary gland in someone's shoulder?
No, but
Okay.
that's the only like, I don't know,
Okay.
like upper region that I can think
Okay.
of. at the moment.
Some sort of malignancy?
Okay, what kind of malignancy you think would pick up iodine?
I'm not sure.
Okay, well, let me just tell you folks, okay, we're talking about thyroid cancer. Most cancers, if you give them a chance, will metastasize. They will spread to other parts of the body. So this is an example of metastatic thyroid cancer showing up later in the patient. And someone saying, yes, I knew that. Okay, so they use this I-131 scan in patients that have a history of thyroid cancer because they're looking for metastatic thyroid cancer. So this is bad news. It's bad to get metastatic disease in the shoulder. But if you look real carefully, you see these dots here. Okay, what organ is here?
Lungs.
Yeah, lungs and heart
Heart, yeah. But
and lungs. Yeah.
this person has metastatic thyroid cancer in his lungs. I'm not 100% sure, but I'm about 95% sure he's got metastatic thyroid cancer, and also down here he's got some dots here. Maybe that dot could represent the bladder, and that's being excreted in urine. But this dot way over here, that's not the bladder. So it's probably in the lymph nodes. That's a lymph node. That's probably a lymph node there too. Yeah, so this person has metastatic thyroid cancer in different parts of his body. This is bad news. Okay, so this is the utility of knowing where iodine goes, because I'm not worried about that. We expect to see that. I don't expect to see that. That's there. Something is wrong. Okay, I think I've tortured you guys enough on that. Again, this is year 2 stuff. Even though I tortured you this is not on the exam. Okay. So question four. Am I having too much fun on this? Are you guys having fun too? No. Okay.
Having a lot of fun. This is
You're
great.
having lots of fun.
Thyroid's awesome, yeah.
Okay, awesome. Whatever. We have
Having
some
too much
masochists
fun,
here.
Dr. Honda.
Okay. So 4 is a 28-year-old woman comes. She thinks she's hypothyroid. You can't find anything when you examine the patient, but you find out she is taking oral contraceptives. And you guys are really astute clinicians, or you checked your books or the internet or something, and you remember that oral contraceptives increase T4, and it also increases thyroxine binding globulin levels. So, if we remember our physiology now, most of T4 and T3 are bound in the blood, right? And most of it is bound to thyroxine binding globulin. And if it's bound to a carrier protein, it's not active, because that carrier protein's job is to take it around the body, around and around. And only the unbound fraction that's actually free in the blood, that can actually get into cells and do what the hormone's supposed to do, okay? So the question is, okay, so we know there's more T4 in this patient. If we just measure T4, total T4, it's going to be increased. And apparently oral contraceptives does something to the liver, so there's more thyroxine binding globulin. The question is, well, what about the free T4? Free T4 is where the action is. What happens there? So let me pick on group 16. Group 16, okay, you cannot escape the evil eye of Dr. Honda. Can you just tell me what you think the right answer is? Just tell me what you think the right answer is. We'll start there.
We went with answer choice E because remembering that contraceptives increase production of TBG, which will then bind more of the free T4 and lower the free T4 levels, which the body will then sense and increase its production of T4. So the free T4 levels should stay relatively normal, even though the increase of total T4 and TBG would increase.
Okay, so what you're saying is T4 increases, so you might have more free T4, but the body is also sending in more carrier protein to suck up that free T4, right? So the net effect is no change in free T4.
I thought it was actually the opposite. The body was producing more TBG, which bound more T4, lowering the free T4, and then the body sensed that and produced more T4.
I would say that's reasonable. I don't think we really know what came first. We're not sure what came first. But let's pick, let's say, C. And I'm going to pick, let's say, a different group. Let's try group 19. Group 19. Group 19, you're looking at C. Now, this is kind of a wordy kind of thing. I guess we're thinking C is not correct. So why is it not correct? it's kind of a tough question because it's asking things that may not have really been discussed at length in the pre-read. How about anyone? Let me just open up to anyone in the class too. How would you explain to someone why C is not correct?
So my best guess for this one
Yeah.
would be that since both are increased, they would increase based on concentration in the solution, and it would still be approximately level according to the normal chemical balances created by the body. It wouldn't leave the more of it is not, it's not avid enough to suck up more than it should, I guess is what I would say.
Okay, so you think there's like a limit to what the thyroxine binding globulin can pick up? You know, they can only pick up so much. And there's only so much thyroid globulin that you can pick up. Am I sort of saying?
Well, I think there's only so much, but even if you increase the concentration of TBG, then the T4 would also increase at the same time.
Okay, because we already stated that at the beginning that T4 is increasing. Okay, so I guess
because if it sucked all of it up, the feedback loop would create more.
Yeah. Okay. You'd even get more. So the body's always trying to keep some free T4 around. Is that what we're trying to say? Is that there's a homeostasis here?
Yeah, that's going to be trying to balance it to a normal free T4. Okay. Exactly.
Yeah, the body wants to maintain a certain level of free T4 and free T3 floating around. Okay. Well, I don't want to torture this too much because the differences are real subtle, and it has to do with, you know, how much T4, T3 is in the blood, how much carrier protein is in the blood, and what is the interaction between those. We really didn't go into any discussion about that in the pre-read, but I just wanted to bring it out just to kind of raise the question that there's some real subtle things going on here within the body. And quite frankly, from my reading of the literature, it's not a clear-cut mechanism. I think some of the things that people have mentioned that, you know, if you know, like Ron's saying, if you drop free T4, then the body is going to compensate, make more T4 until it gets more free T4. It's going to, if need be, it'll saturate all the carrier protein, so it has something free. So any other comments or questions from anyone? Or it's just like, thank God, let's finish this and go on. I'm sorry, someone had some comment?
Yeah, I had one question, Dr. Nanda. Is that
okay?
For this one, could we assume, just in normal circumstances, that if you have an increase in TBG, then you would have a decrease in free T4 and vice versa? Or is that not the right assumption?
Not necessarily. I think if anything, the opposite is true. I think what we're trying to say is the body wants to maintain a certain level of free T4 and free T3. And the body will do what it has to keep that level going. And it is true that, you know, the liver is making more carrier protein. And so the body has to compensate. I'm not entirely sure why the body makes more T4 if you're taking oral contraceptives. I think there's some thinking that it's the estrogen that's going directly to the hypothalamus, like that, increasing the TRH, et cetera. I mean, there's much more complicated things going on when it comes to oral contraceptives here. Okay, well, let's go on here. Let's not beat this to death. Okay, and in the pre-read, basically all we had here were these two tables. What increases thyroid binding globulin? Now this is a potential test question. You just need to know that thyroid binding globulins are increased in pregnancy because there's lots of estrogen running around, oral contraceptives against the source of estrogen, and estrogen by itself. And what decreases thyroid binding globulin, usually it's things with liver disease, like if someone has cirrhosis where the liver is not working very well, then you have decreased levels. Nephrotic syndrome, you have a decrease because your kidneys are excreting all the protein, including all the carrier proteins. Okay. And just this cartoon is just to kind of emphasize sort of what's going on and to introduce some other factoids that come into play later, not in this particular question, but your thyroid's producing T3 and T4. It produces a lot more T4, about 85-90% of all the thyroid hormone being produced with thyroid is T4. And then both T4 and T3 are carried by the carrier protein, thyroxine binding globulin here. And then you have this real small fraction here of free T4 and a very small fraction of T3. And I think what we're trying to say in our discussion is the body is monitoring these levels very carefully and wants to maintain that very narrow range. Okay, enough of that. So the answer is E.
Hey, Dr. Honda, can I ask a quick question?
Okay.
Can we think of T4 as almost a pro-hormone for T3? Because isn't T3 what actually causes action in the body?
Most of the pre-read implies that T4 doesn't do anything, but I guess you could think of T4, it's just a reserve for it being transformed to T3. I never really thought of it as a pro-hormone. I'd have to think about this, but I think T4 by itself has some action on the body. Even though the body transformed most of it to T3 before its action. I think the problem could be, I'm not aware of any experimental model. You'd have to have a rat that has no T3. So I guess if you can breed a rat that's missing the enzymes that it won't transform into any T3, we could test this, but to my knowledge, there is no rat like that. So do we have I know we have some members of the class that have masters and PhDs. So I don't know. Do we have someone with a background in physiology? Have they heard of any experiments that were able to look at just the effect of T4 and just the effect of T3? I'm open to ideas. I mean, okay. Well, I'll just leave it as I don't think we know. I don't think we think of T4 as a pro hormone, but I'm not 100% sure. Okay, let's get through this. This is dragging on. Okay. Thyroid hormone receptors. Let me just go through this real fast. The answer here is E. It's within the nucleus, right? Because thyroid hormone is a hydrophobic hormone, even though it's made from L-tyrosine, and most of the products of L-tyrosine are hydrophilic. This is one that's hydrophobic. Now, all hydrophobic hormones go to the nucleus. Okay, that's a quick answer. And then the pre-read has all this other extraneous information about, here's the receptor in the nucleus, and it also requires this retinoid X receptor, mechanism. And right now, it's sort of like, that's interesting to know. Does it have clinical effect? I'm not aware of any, clinical effect. I'm not aware of any particular drug that binds to the XRX. So it's within the nucleus. Okay. So here's a question talking about T3 and T4. Okay, so basically, we're talking about hyperthyroidism, right? If you have too much, what kind of symptoms are you going to get? And let me just pick on a group real fast, just to make sure everyone's still awake. Bright-eyed, bushy-tail. Let's try group 2. Group 2. Can someone just tell me what the answer is?
Increased gastrointestinal motility.
Okay, that's good. And this question is just taken from, this particular slide. It tells you what thyroid hormone does to carbohydrates, what it does in general, blah, blah, blah. So I just picked these things and then put that to the question. And unfortunately, you probably have to memorize all these things. I did get a question late last night about this. Why is it that high levels of thyroid hormones reduce glycogen synthesis? I tried to run it by Dr. B this morning, and he kind of gave me a quick nod, but I really want to sit down and go over this with him. But this was brought to my attention that when you think about it, that's counterintuitive. But the main question is it's low thyroid versus high thyroid. So we're probably talking about pathologic states here. So I'll try and get that clarified with Dr. B, and if maybe I'll put something in the announcements. Okay, so unfortunately, I'm putting this on your plate. You just have to read this carefully and either memorize it or just think in general terms like, okay, if my basal metabolic rate is increased, what would you expect? And when you think about if your basal metabolic rate's increased, then you would expect everything else to be increased, blah, 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 everything is increased. And then over here, if your basal metabolic rate's increased, what would you expect? It kind of fits to this pattern. You have to think out what the processes are. Okay. Oh, now this is getting tricky. This is getting clinical, but I will assure you there will be questions like this. And though it's reeks more of second year, I think most books include this under first year material. So it's basically asking you to take some labs. We just tell you if they're high or low, and you've got to figure out, where is the problem in the patient. So let's pick group 10. Group 10. Someone from group 10, just tell me what you think the answer is.
Sure, this one is E.
Okay.
Because of the high levels of thyroid stimulating hormone.
Okay.
It points to a secondary hyperthyroidism because there's got to be some kind of Wait, did I get that right?
Okay.
Yeah. Okay. Yeah. There's got to be an insensitivity at the pituitary gland.
Okay.
To the feedback.
Okay. So let's kind of go through this stepwise for the sake of everyone else. We're just telling you the patient has elevated T3 and elevated T4. So we know this patient is hyperthyroid. Okay, and if this person had an intact negative feedback system, you would think this increased level of T3 and T4 would go back to both the anterior pituitary and to the hypothalamus and tell these structures, hey, we've got enough thyroid hormone, shut the production down. And one of the messages is TSH, but TSH is elevated. So something's wrong, right? TSH should be low because we don't need more T3 and T4. So because the TSH is high, we know something is wrong with the system, and it kind of points to the pituitary gland. Okay, so this is an image from the pre-read. If you don't get it intuitively, just memorize it. You memorize this, you'll get several answers correct on the exam. There's no question about it, because this tests your knowledge about certain things. Now, it's better if you understand why it does it, but if you can't, just memorize it. So again, this patient had high T3, T4, so we're talking about these two entities. They're hyperthyroid. And if you're hyperthyroid with high TSH, then it's secondary hyperthyroidism. So if all else fails, memorize the chart and boom, you got the answer. But it's better if you understand why. And we'll emphasize this again in the applications. Okay. That. Now, this one's kind of tricky here. Okay. So let me pick on group 1. Group 1, can someone tell me what they think the right answer is?
So we put A, I believe, that
Okay.
it is active, so it'll produce more
Produce more
of the reverse T3.
Reverse T3. Okay, so what's the key statement here that really drives this to be the right answer?
That reverse T3 is inactive.
Inactive. Okay, that's the key point. Okay, so this kind of serves as a secondary mechanism to control thyroid hormone. My understanding is it's not really powerful. It helps to fine tune the level. And so, again, this diagram kind of summarizes it in cartoon form. I don't like this diagram because the labels are very small, but basically you have lots of T4. Again, someone asked, is this a pro-hormone? I didn't think of it that way, but basically you have T4 and you have two different enzymes here. One makes T3, reverse T3, that's inactive, and that because it gets rid of that iodine, leaves that iodine here. And it also makes T3 active, depending on which enzyme. And the name's really confusing. You know, they're both a deiodinase, but one is 5, one is 5 prime. That's why I have this big green arrow here. So if you see this in a question, you've got to look and say, okay, is this a 5 prime or just a 5? Because that makes a big difference here. The 5 prime will make the active form of T3. And these questions will usually appear as distractors. So you just have to know this. This is something you just have to know. You have to pay attention. So the correct answer is A. Reverse T3 is inactive, and so the body increases production of RT3 relative to regular T3. Any questions about that? Okay. Okay. So again, this is a situation where we present you with signs and symptoms. You can kind of look at this. Kind of sounds like the patient of the week, right? Remember the patient of the week? Blah, 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 blah. Now, you may notice this too, that usually when they talk about hypothetical patients, they're all females. That's because females are at greater risk for thyroid problems than males. I'm not entirely sure why, but when a female comes in with symptoms, you're thinking, could it be thyroid? Because it's just more common in females. And so you do an exam, blah, blah, blah. You're thinking it's hypothyroid, and then you have to look at these results. So the question is, what row of laboratory test results would you expect? Let's just get another group here, going here. How about group 8? Group 8. Tell me what you think the right answer is.
We thought that normally, since T3, since the patient is what's the term, hypothyroidic, the T4 and T3 should be low, and because there's no negative feedback, TSH would be high, so we went with C.
Yeah. There's actually another combination, but this is the only combination where both T3 and T4 are low. And in all honesty, I'm not really aware of a situation where T4 is low and T3 is high, or vice versa. T4 is high and T3 is low. Usually T3 and T4 are highly correlated. Second year, we'll probably find some example of this situation where T4 does not match T3. But in this case, you're correct. Your reasoning is correct, and I like that. So again, if all else fails, just memorize this chart and you can figure out where it is. So we have a patient, let's see, let's go back up here. We had low T4, T3, but high TSH. Okay, so going to this, we have a low T3, T4, so second is hypothyroidism, and we had what, high TSH, right? High TSH, so it's primary hypothyroidism. So something is wrong with the thyroid gland itself. Okay, so if you can't work it out in your head, just memorize the chart. Okay, now this is the wild one. Let me just pick on someone real, no, pick a team here. Pick a team, any team, 15. Tell me what you think the answer is.
We marked answer A, which says that the Wolff-Chaikoff effect is a form of thyroid autoregulation.
Okay.
Which is also true for B through D, but B through D doesn't accurately describe the actual mechanism of how it works. I think it's the opposite of B pretty much.
Okay. So all these are sort of like describing things that just aren't true about what we're talking about, Wolff-Chaikoff effect. Okay. So I did some searching, and this graph is usually not shown in physiology books. It goes back to their original experiment, where Wolf was a graduate student working in a physiology lab, and his instructor, Dr. Chaikov, told him, hey, we're going to figure out what happens to rats if you give them lots of iodine. And so what they used was radioactive iodine. That was sort of the big thing at the time. And they would give different doses of radioactive iodine to rats. And if I recall correctly, then they would sacrifice the rats, dissect out the thyroids, and see, how much radioactive iodine was actually in the thyroid gland. And so what they found out was that as you give increasing levels of iodine, or radioactive iodine technically, that initially the uptake of radioactive iodine went up briefly and then start to come down the higher the dose that you gave, which didn't make sense to them because, the original thought was, well, heck, the more iodine you throw at the body, the more it's going to incorporate it into the thyroid globulin, the more thyroid hormone you're going to get. In fact, it's just the opposite. The more iodine you give or the higher dose, it starts to shut off the whole mechanism. The body shuts down and stops producing thyroid hormone. And it's at the step of organification. So even though the original graph shows that it actually goes up, the basic statement that you'll find in books is the overall Wolff-Chaikoff effect is you increase iodine, you decrease organification. Okay. So again, that refers to the thyroid regulating itself. It doesn't need information from the anterior pituitary or the hypothalamus to tell them what the iodine level is. The thyroid just figures it out itself. And it's kind of interesting. I'm always kind of looking for mnemonics, and someone on the internet said, well, here's the mnemonic to remember Wolff-Chaikoff. You think of a wolf drinking chai coffee. Wolf drinking chai coffee. So that's Wolff-Chaikoff. And the word off means that it shuts off thyroid production. So wolf, chai coffee, off is a way to remember. Does that help you? I don't know. You have to tell me later. I find this very humorous. So it's a form of autoregulation. Wolff-Chaikoff will come back many times. I think I mentioned in the pre-read that one of the applications is some medications have lots of iodine in it. Not because they wanted iodine, but it just happens to be part of the drug formulation. And patients who take these drugs can have the Wolff-Chaikoff effect. In other words, they take this drug for something else, and suddenly their thyroid starts to shut down. Whoa! So this is something you got to keep in your back pocket. It'll show up again, and I think we may discuss a little bit more in the applications. So, any burning questions, desires right now? I think this went much longer than I thought. It's probably because I'm in an evil mood right now, and I'm torturing everyone. So let's take at least a 10-minute break. Okay, 10-minute break. So let's be back at 9:35 or so, 9:35, and we'll start the applications.
Do it, Ron.
Test. Hey, y'all.
Okay. Actually, I'm kind of curious. I think I only gave you 20 minutes. Was that sufficient time to make a first pass through the questions? Okay, I'm getting some thumbs up. Okay, good. Well, let's just dive into this. And like I said, I hope to get through early. Now, you should see a screen that says TBL3 applications. Someone give me a thumbs up if that's what they see. Okay, good. Okay, good. Okay, so let's dive into this here. Okay, blah, blah, blah. Athlete is taking a bunch of thyroxine pills right before a marathon. And the question is, what is a handful of thyroxine pills going to do to you? And so let's have a group just kind of help us out here, group 11. Why don't you tell me what the answer is and then why you think that's the right answer?
So I think we put D because we thought the timeline of just a day would not be long enough for the slow releasing effects of thyroid hormone to exhibit its effects.
Okay. And does pretty much everyone in your group agree with that?
Yeah, we
Okay.
all are in agreement.
Okay, good. Well, let's just dive in. And basically, it has to do with this one graph. It's in the basic physiology book, and it shows an experiment where they just given actually the actual graph comes from an injection of thyroxine, but I'm pretty sure if you take a handful of thyroxine pills, it's going to be very similar. The timeline may be shifted a little bit. But the basic take-home message is when you get a lot of thyroxine as a bolus, it takes days before you see a change in the basic metabolic rate. So that's one of the effects of thyroxine. There are other effects, but that's the basic effect. And it takes time for it to get involved in the body. And then once the body is jazzed up from all this thyroxine, it takes days, almost weeks, for that effect to wear off. So as you said, it's the effect is slow onslaught here. So you are correct. The answer is D. The athlete will have no change in performance from the pill for the day. Okay.
Dr. Honda?
Yeah.
I had a question about one of your slides talked about how a high increase in T4 gets converted into reverse T3, and reverse T3 competes with T3. So I thought that the athlete will exhibit decreased performance for the day. So can you speak to like if that occurs or not?
It probably does, but again, the transformation of T4 to reverse T3, it's a secondary control mechanism, and it plays a very minor role. That only kicks in when everything else has taken this attempt to control T4 levels. Probably in this case, going back to the graph, this is measuring basal metabolic rate. Probably the T4 level is sort of somewhat behind the curve here. That again, there's an increase in T4 actually in the blood. It takes time for it to get in, and it may peak a little bit before.
Okay, thank you.
Yeah,
so much.
I don't think the mechanism of converting T4 to reverse T3 is going to have much of an effect here.
Okay, thank you.
Okay. So the secondary question is, a week has gone by, and hopefully she hasn't stolen more thyroxine pills from a relative. And what kind of symptoms would we expect to find? Just anyone. Just shout out what you think the right answer is.
My team put A, palpitations and increased sweating.
Okay.
B and
what do you
C
think
are also
about?
reasonable, but they would be more chronic, probably.
Okay, so that's why B, C, D, E are probably not a good answer because it
DE
takes.
looks like it would be associated with hypo.
Yeah, E is hypo, and some of these other things take probably months to years before they manifest itself. Now that's sort of an extra tidbit. I don't think we really talked about when these signs and symptoms appear on hyperthyroid patients, but it takes time. And I would emphasize too, things like they always show pictures of exophthalmos, the bug out eyes. I myself never saw this, when we get an endocrinologist working with us, us too, that one of the questions I want to ask is, how often do you see this? Personally, I think it is rather rare to find that. Okay.
Can I ask a question about that really quick, Dr. Honda?
Yeah, go ahead.
Sorry, just is exophthalmos like specifically related to Graves' disease, or is it a general long-term symptom of like any form of hyperthyroidism? Because I went back and looked. Sorry.
Yeah, I think it's specific for Graves' disease.
Yeah.
Because it has to do with antibodies, and these antibodies not only affect the thyroid, but they affect these specific tissues that are behind the globe.
Okay, so could it potentially also maybe wouldn't appear in this patient since she has increased T4 because of the pill she took rather than having Graves' disease? Okay.
Right. I think that's a good point.
Thank you.
The other point from the pre-read is that there are other conditions that can cause exophthalmos. Basically, anything that causes swelling of soft tissue behind the globe can cause exophthalmos, of which hyperthyroidism is only one of them. Okay, question 2. Let's see. This is a bunch of wordy stuff here. Let's try group 12. Group 12, someone tell me what they think the answer is. Someone from that group, can they chime in, or did they absolutely zone out? Okay, I'll assume they just zoned out. Let's try 14. Group 14, can you just share with us your thoughts on question 2A?
Sure. So for this question, we're looking at elevated TSH, T3, and T4.
Mm-hmm.
So we're thinking about the anterior pituitary, something being wrong because there's a lot of TSH being released and therefore a lot of T3 and T4.
Okay.
So I believe we went with secondary hypothyroidism because we're suspecting something's wrong with the pituitary.
Okay, answer B. Okay. So again, this refers back to this graph, and I'm telling people if they can't think of why this is so, just memorize it. So basically, we have. Let me go back here. So we have elevated T4, T3, and TSH is also markedly elevated here. Okay, so go back here. It's T3, T4 is elevated, so some type of hyperthyroidism, and the TSH is also secondary hyperthyroidism. You got that correct. And usually these are due to something in the pituitary gland, not with the thyroid itself. So something's wrong with the pituitary. It's giving out way too much TSH. It's gone rogue here. Okay. And so the secondary question was look at this image, and we did use the term lesions. So we're saying there's something going on with the pituitary gland, and when you take a view like this pituitary gland is. So what do you think the answer is there? Let's use the same group. What do you think? How would you answer this?
We went with answer choice B, pituitary neoplasia.
Okay.
Yes.
Okay. I think you can come to that because you have too much TSH. So usually that implies a neoplasia, like a pituitary adenoma is producing too much TSH. Could it be pituitary necrosis or the empty cell syndrome? Usually that causes pan pituitarianism. In other words, all the anterior pituitary hormones decrease considerably. So that's a pan effect usually. Usually it's not just one hormone. Pituitary cysts or Rathke cyst, usually, even though we use the term cyst, usually it's more of a mass, and that would be a mass effect, but usually these don't secrete any hormones. And it's not a normal pituitary just because it's too big. And you just have to get a feel for what pituitary looks like. Remember, pituitary is a relatively small gland. Oftentimes they say it's the size of a pea, but actually it's a little bit bigger than a pea. But this probably is more the size of a very large marble, I guess. Okay. And so here's our large pituitary here. The empty sella syndrome is where usually it's due to necrosis of the pituitary gland. It's seen in one syndrome where the patient has an episode of hypotension. There's a total loss of blood pressure. There's no blood going to the pituitary dies. Then over time, that tissue gets reabsorbed, and all you get is this amorphous, sort of grayish looking stuff here filling the sella tristica, and that's just CSF. And again, if you're not sure what's in there, is it tissue or is it CSF? You just have to look at what's in the sinus. That's air. That's very dark black, and then try and find CSF over here. That's sort of more light gray, and this is probably more light gray. It's not this sort of muddy gray that you see in tissue. So hopefully there's enough information in the image to say that's CSF. And then finally, Rathke cyst, as I mentioned, usually it's more of a mass lesion. And this one, the radiologists use this term, it's got the claw sign, it's like something grabbing around it. And we really don't see it this well in this image. And I'm kind of surprised that this got published, because you probably have to use a different T1 signaling, and they claim that there's viable pituitary tissue forming a rim or the claw sign. So, but believe me, this is something we would not ask on the exam. This, possibly, that's something I think you can reason out. So the answer is enlarged pituitary, probably pituitary adenoma. My understanding is pituitary adenomas that secrete only TSH are extreme. They do occur, but they're rare, very unusual. Okay, 3. Let's come back. Group 17. I don't think I've called on you today. Group 17. Just tell me what you think the answer is, and if possible, kind of let us know the logic behind it. Group 17. What happened with group 17?
Yeah, so we were looking at T3. We saw that T3 was low, and then we saw that TSH was high. So we honed in on that and went with answer choice C, primary hypothyroidism.
Okay, I like that. Okay, so primary hypothyroidism. And I'm a broken record right now. Again, you can just go to the graph if you have to memorize it. So T3, T4 are low. So we're dealing with this row here, hypothyroidism. And TSH, let's go back here, was high. Okay. So we're over here. So that's primary hypothyroidism, or something is wrong with the thyroid gland itself. And that was the example, I believe, of our patient of the week. Oh, let me just throw a little tidbit in here about the patient of the week. I think in the pre-read I mentioned that hypothyroidism is a tricky diagnosis to make. It's more common than we think. But when you think about the patient of the week and the symptoms that she had, cold intolerance, irregular periods, for the most part, they're somewhat non-specific. And I think I could see where if this patient showed up in someone's clinic or a walk-in clinic or something, you may think it's something else altogether. You may think that it's more of a GYN problem. Maybe she needs hormone replacement therapy, or maybe there's something else going on with this patient. It's not thyroid. And I think I had a series of pictures in the pre-read of someone's face changing with hypothyroidism. And the point there was that the changes, the physical changes, are very subtle, and they take years to develop, and you may miss that. There's a story I heard. I have no idea if it's true or not, but going back to anterior pituitary surgery, we go through a transfernodal procedure where the surgeon goes through the nose, through the sphenoid sinus to extract out a tumor from the pituitary. The surgeon who developed that technique, Cushing, I believe was at Johns Hopkins. And when he developed this technique, neurosurgeons from across the world flocked there because they wanted to learn this technique. And so he always had all kind of neurosurgeons training under him because I wanted to learn this technique. And the story was at Johns Hopkins, there was some diner just across the street from the school. And that's where a lot of the faculty went for a quick lunch or something. And so, one day they had a brand new neurosurgeon come who wanted to learn this technique, and he went with them to the diner and they sat down. And this guy looked up at the short order cook, and he says, "You have acromegaly. I think we need to get you on the operating room and look and take out your pituitary adenoma." And everyone else was like shocked. It's like, hey, this is Joe. He's behind the counter. He's been serving us, sandwiches and hamburgers and milkshakes for the last 20 years. Why do you think he's got acromegaly? And he says, well, just look at his face. And lo and behold, the story goes, the patient or the guy that worked in the diner really did have acromegaly. But the point was, these changes take a long period of time and they're very gradual. And these neurosurgeons who operate on people, every week with the syndrome just totally missed it because they had seen this worker, literally every other day for years and years and years and didn't see the changes. It took someone coming from the outside to see the patient. This is to point out what to him was obvious. So again, just to point out that we often use cartoons and photographs of really dramatic cases, but especially for hypothyroidism, the changes you may not recognize until years later. Then you go back and find photographs. Oh yeah, there really were changes there. So just be aware that this can be a very difficult diagnosis to make just based on signs and symptoms. Okay. And 4A. So let's pick group 20. I don't think I called group 20 yet. Group 20.
Yeah, so
yeah.
For this one, we saw that T4 and T3 were low, and TSH was also low. So we were thinking it was secondary hypothyroidism.
Okay. Again, the same thing here, hypothyroidism, and everything is low. So it fits into that category. So we're thinking the thyroid itself probably is okay, but the hypothalamus, maybe there's something wrong up there. No, I'm sorry, the thyroid, I'm saying this wrong. The thyroid is okay, but something is going on with the anterior pituitary or the hypothalamus, something above it. Okay, so secondary hypothyroidism. Okay. And the story was this patient had history of tuberculosis. She's also coughing. She's got a low-grade fever. And so the question is, do you think her tuberculosis could be the cause of this? And I think there was some groups that had different answers about this, but why doesn't some of this shout out what they think is going on here?
So
We read a couple. Oh, go for it.
Nope, you rock it, Ricky.
No. Okay, well, we just read a couple cool things that like the posterior pituitary gland isn't inside the blood-brain barrier, so it potentially is open to infections. I actually don't remember. I think we went with C because it was like the safe choice. Like, yes, it may involve the pituitary gland and cause hormonal dysfunction.
Okay.
Because we couldn't rule it out, but I'm trying to remember what we actually put. But we did find that cool little tidbit.
Okay. Does anyone else want to throw in their 2 cents, what they think, what the right answer may be?
Yeah, we agreed with C because I know at the very end you briefly touched on in the pre-read that TNF alpha and IL-6, which are both inflammatory cytokines, can affect it, but it decreases the TSH. So we ruled out D because the increase in TRH didn't make sense to us, I think.
Okay. Well, let me just preface this, that what I was trying to get at was a case of TB that has spread throughout the bloodstream, and TB has infected the pituitary gland. The infection has actually destroyed most of the pituitary gland. That's why it's not producing TSH anymore. I was kind of curious, how prevalent is this? So I did a quick search, and apparently there's only like 5 or 6 cases of this reported in literature. So this is, the other factor would get really mad at me saying, well, why are you presenting super rare stuff? But the reason I'm doing it is I just want to point out that other disease processes can affect the pituitary gland, and it can lead you astray if you're not careful. And so I think that's always a good idea when you're approaching a patient in the hospital that, you're just really not sure what's going on with the patient. You should kind of keep in the back of your mind, is it an endocrine problem? Is it an endocrine problem? And if it's an endocrine problem, is it a strictly endocrine only type problem, or is it because something else is going on affecting the endocrine gland? So this is the case of the endocrine gland itself was originally intact, but it was a disseminated infection that is affecting the pituitary. I think this other distractor of D about, is it really the fever component of the disease? And, that's a possibility. I think it's something to be thinking about. And I think someone mentioned interleukins. In all honesty, I wasn't thinking about interleukins at all. But this answer is incorrect, because if the fever affected the hypothalamus to release thyroid releasing, actually it's thyrotropin releasing hormone TRH, then you should have an elevation of TSH, and this patient has low TSH, so it doesn't really make sense. There's the first error is thyrotropin, not thyroid releasing hormone. So it's just a reminder that the hormone system will interact with other systems altogether. So you just need to keep that in mind. And this was a very difficult scenario to kind of weed through. I think that's it. Yeah. So we got through this in record time. I think my first question would be, was 20 minutes enough time to get through these questions, or did you need more time?
That was a good time.
Yeah, it was okay for us.
It's okay for you. Okay, good. So maybe these application sessions we can shorten and tighten up a little bit. And I think I'm pretty much through with the application. So I'm going to let you guys go early. I hope you don't mind. Again, I'm always kind of worried that if I'm letting you go, am I not giving you enough material? I don't know. I really, really don't know. So we'll meet again, I believe at 1 o'clock for a CIS session. It's scheduled for 2 hours, but in no way, shape, or form can I give a presentation for 2 hours. So it may be just a little bit more than an hour. So I think you're going to have lots of green time today. Again, I'll emphasize that next week covers a lot of material very quickly. And I would encourage you to get ahead of your reading, both the TBLs and ILSs, because there's a lot of material in each of these sessions, and then boom, you have the final in a week. So unfortunately, there's not much time to digest some of this material. So get cracking early. So this weekend is not a time to slack off. This is when you really need to buckle down. And then after the final, you have spring break, right? Yay. Okay. So I'm sorry, this weekend, you got to put in the time. But after the final, you got a week. So,
Dr. Honda, I had a quick question too.
Yeah.
So this is kind of unrelated, and if you'd rather me email you, that's fine. I was looking at for it's for hyperthyroidism, and there was that pretibial mixed edema. Yeah, and then so I was looking at basically, and then I saw elsewhere that the mixed edema was more commonly associated with hypothyroidism. And so I didn't know if that the pretibial, like that location, was more specific to hyper, and then maybe like I think it was eyes and tongue was more related to hypo.
Yeah, I think it's confusing too. I'm not entirely sure of what causes pretibial myxedema and why in hypothyroidism you just get more generalized edema and it's more centralized in the face. I can't explain why that's so.
Got it. Okay. Yeah, so it's more location wise though than if we're going to try to differentiate them.
That's my understanding, right?
Got it. All right, thank you.
Okay, so good. Have a nice lunch. Try and get a little bit studying in, and we'll see you at 1 o'clock.